has changed. To summarize once again, we are not strictly following today the step-by-step care approach. We are going for combination pharmacotherapy, maybe from rather earlier on. We have become much more aggressive. As the preferred secretagogue where cost consideration is not an issue, DPP4 inhibitors are largely replacing the sulfonylurea secretagogues. Though having said that, I would at the same breath say that it is not yet time to write off the sulfonylureas altogether, as I think the SAAC is trying to do, but sulfonylureas still have a place in the treatment of type 2 diabetes, but I think DPP4 inhibitors are preferred as a class over the sulfonylureas, and sulfonylureas at best may be added later on. But what has engineered this change? What has brought about this change? First, as I've said, the spectacular success of the DPP4 inhibitors as a class. Then, of course, the knowledge gleaned from studies such as the DCCT-ED and 10-year follow-up of the UK PDS, prompting us to go for aggressive control right from the day one, and the experience from Accor Advance and VADT actually prompting us to avoid hypoglycemia, to avoid agents that have a high propensity of causing hypoglycemia as much as practically feasible, and of course the safety concerns of solid diets. And of course, individualization of targets and treatment is the key. Not only treatment, individualization of targets is the key. Now we are having and we would be having a lot of guidelines and treatment algorithms. They are very useful in guiding the clinicians, but I think they should not be viewed as something sacrosanct. The physician's decision, physician's judgment in treating the patient should be supreme, and if the treating physician has sufficient reason to deviate from a prescribed guideline or algorithm, I think a physician should be allowed to do so. And of course, you have to dichotomize your patients, you have to select your patients. Some of the patients, poor patients, not in the reimbursement sector, which come to my hospital where I work in, despite knowing the benefits of DPP4 inhibitors, I have to fall back upon the cheap sulfonylureas as a secretagogue. But then in the reimbursement sector, then in certain professions, as I said, in train drivers, airplane pilots, those who are driving public vehicles, and in certain professions and in certain comorbidities, I think one should choose agents which have lesser chances of hypoglycemia. And of course, DPP4 inhibitors offer the prospect of tight glycemic control without the side effects. That has all really has changed the scenario. And of course, I think another group of agents would be very closely watched in a couple of years to come. That is the SGLT2 inhibitors. I think canagliflozin would be available soon. But I think the promise of canagliflozin, or for that matter SGLT2 inhibitors, will be a little bit, has to be tempered with the prospect of genitourinary sepsis that has been in the literature, but only practice will make us know how troubling or how bothering is the genitourinary sepsis as a side effect, or it's really in the realm of hearing. So, ladies and gentlemen, this was one of the activities, programs of last World Diabetes Day, the right environment for all, and the slogan for last year's World Diabetes Day was Diabetes Protect Our Future. So I think this has been consciously coined, keeping the current state of affairs in mind, because in diabetes, our main aim is not to ensure the present of the patients, but to protect the future of the patients, protect them from complications, and that too by effective good treatment, aggressive but reasonable, judicious glycemic control with the agents that are available. Now the therapeutic armamentarium has expanded and is ever expanding than before. Previously we had only 2 agents, sulfonylurea and metformin. Now we have 5, 6, 7 agents, maybe a couple will be added in the future. So I think the future of the patients of diabetes appear bright. If not that bright, at least we would have greater options in future to choose from. Thank you. If you have a few questions, quick questions, I think I would be glad to address them.